Loud and clear.
Thank you. So we have the recency testing. The definition is a diagnostic tool that helps to distinguish among newly diagnosed persons those who have acquired HIV infection recently.
Karen, can you move the slide, please? Can you move the slide?
I'm in the second slide.
You have not moved it. Can you move it?
Are we there?
Not yet. Can you move the slide?
Are we there?
You haven't moved the slide. Can you move the slide to the second slide?
Are we there? Can you see the slide?
You
Yeah,
haven't
you can
moved
see the
slide.
slides. The slide that you can see is the one on HIV recency testing. Are you
Yeah,
able
that
to
is
move
what
to the
we are.
next one?
Yes.
Okay. So
we
So
have
you
the
can
recency.
proceed.
We have the recency
Can you try
phenomenon.
move to the next one?
Are we there at the third slide? Can we see the slides?
Okay, it's still on the first slide. You haven't moved the slide.
On my side, the slides are moving. Are you seeing the slides? The screen sharing is paused.
Can you unshare and then you share again? We can see the first slide, but it can't. But it's not moving. So, are you able to unshare and then you share?
On my side, it said that the screen sharing is paused. So let me share it again. So are we there?
I'm requesting you to unshare. You stop sharing and then you share again. Maybe it will move. Can you stop sharing and then you do it again, kindly?
So I move from sharing.
You stop sharing. Can you stop sharing? Okay. Can you go to the first slide?
Are we there?
Okay. Can you go to share or presentation mode? Very good. Can you now go to your first slide there? You can proceed now.
Is okay. So the first slide is HIV recency testing, application, benefits, challenges, and priority action points.
Very well. You can now go to the next slide and you pick from where you are beginning.
Our objectives are: 1, the overview of HIV recency; 2, application of HIV recency in HIV management; 3, recent infection testing algorithm, the RITA; 4, implementation of HIV recency, benefits and challenges. Then 5, priority actions. So we have the definition of recency testing. It's a diagnostic tool that helps to distinguish among newly diagnosed persons those who acquired HIV infection recently, that is within 6 to 12 months, from those with a long-standing infection greater than 12 months. The reason why the recency is more important in that diagnosis, it's helped us to identify those who are having current recent infection and those who acquired the HIV long time ago and maybe had not accessed testing. This helps to identify population and areas with ongoing HIV transmission for targeted and enhanced intervention. Because testing is an entry point for prevention, treatment, and care. Recency testing makes HIV intervention more intensive, efficient, cost-effective, with accurate surveillance data on incident rates. Then we have the recency phenomenon. When we talk of acute HIV, this is the phase where there is dissemination of the virus from an infected person to non-infected. And during this acute HIV infection stage, we have the virus itself, which has been introduced into the infected person, being disseminated, giving a rise to the HIV RNA virus. And also at that acute HIV peak, the RNA copies are very high. And the P24 antigen also, from the time of infection, it's disseminated. Reaching the acute infection, the peak becomes higher. And as the peak reduces, the antibodies are formed as a result of the antigen stimulating the formation of the antibody. Then we start having the antibody rise. And with the antibody which are rising, we have the GP41 and we have other antibodies like the P29 and 120 antibodies. And this is very critical when we are talking about the recency infection, because for a client which has just gotten a recent infection, we'll be having higher copies of the viral particles. Background: as the world makes progress towards HIV epidemic control, there is increasing need to identify specific geographic areas and population with increasing risk of ongoing transmission for targeted HIV interventions. It's very important for us to understand the epidemiological distribution of the HIV, which is also going to help in determining areas which are hotspots and needs the intervention and the programs in place. 2, doing so helps to direct and relocate resources, majorly to population at high risk, this making the unit's global target of 95 more visible. So when we have the global target of 95, 95, 95, our first 95 is majorly targeting the testing. And if everybody has tested, we are going to know who is positive and who is negative. Even to the negative client, we still need an intervention. Both to the positive client, we still need an intervention. Currently, a multi-faceted approaches that include enhanced identification of regions and population with ongoing transmission have been approved and implemented in several countries. So when we're talking about the global, we are checking which are the areas which are still having the ongoing transmission. And with this ongoing transmission after the identification of the areas, it will be very easy for the interventions to be put in place for the needy clients who really need to be help in preventive measures of towards HIV infection. Among the approaches is a geospatial analysis of regional HTS data, EMR, that is electronic medical registers, to assess and map granular geographical clusters of new HIV diagnosis using geospatial and remote sensing software. How do we use that? Every month we are giving our data reports of the tested from our HTS sites, and they are keyed in through the EMR. And from there, when the data are analyzed, we get the number who are infected and the number we are not infected. Then use of point of care rapid test and ELISA assays in combination with clinical history, that is viral load and antiretroviral therapy metabolites assays, can help to determine the recent infections based on approved recent infection testing algorithm. So far, we only have one point of care rapid HIV test for the Recency, which is the Asante. But because science is dynamic and we are moving towards using this as a surveillance, we can have more of the point of care test in use. HTS data source and aggregation. All HTS facilities report the total client tested and the number newly diagnosed with HIV to the Ministry of Health through the Kenya Health Information System version 2, that is KIS platform. So through this platform, as we make our reports monthly, right from the sub-county to the county to the national, we can access the data and have the total number of clients tested at a facility, then lumped up as per the sub-county, then to the county, then to the national level. These data are then aggregated at the facility and county levels for analysis using geospatial and remote sensing software. So with the statisticians, they can use the data and have the data to speak to the country what is our HIV prevalence currently. From the analysis, HIV-infected persons are shown well distributed randomly with certain geolocations, which then inform the target intervention. So far, apart from the data we have, we cannot just randomly say area B is having high infections or area B is hotspots for HIV infection. But we need to get a data. And through this data analysis, we can now see which are the geolocations, the areas which really need to have that intervention. And the programs can come up to help the intervention in HIV preventions. Then we have an overview of recent HIV infection. This is a study which was pulled out from Siaya County. And the study is showing us the areas which are having higher number of HIV infections in Siaya. As we can look at that, diagram, we can see that the areas which are marked, maroon or reddish, they are the areas which have higher new HIV diagnosis. And this is very important when it comes to intervention, because through the testing, the people might have gotten infected and they didn't know apart from the time they were tested. And that is why the Recency will now differentiate or distinguish between the recent infection and the long-term infection. Then we have areas also which are having lower new HIV infection. So as we can look at the diagram, around the southern Nzoia, around the Lake Kanyaboli, around the Ndere, and around Ndori towards Bondo, we are having higher incidence of HIV. And looking at the geolocations, we can see these areas are more or less towards the lake shore. Like the area we have, the more around Boro area, we have an artificial or man-made lake, which is called Kanyaboli Lake. And also towards the Ndori area where we have the Asembo Bay, we also have higher prevalence. And this tells us that the epidemiological infection in Sierra are mainly due to the mobility of the fishing community and their socio-economic factor. Then now let's look at the countrywide, our country, Kenya. As much as we are working well for the target of reducing the HIV prevalence, which is by 2030, we have moved a step according to the journal of 2020. We've moved at 84% for the identified people having HIV. Then for the ones on Earth, we are at 73. And for the ones which have achieved the viral suppression, we are at 62. So we are still slightly far away from the 95, 95, 95, which was anticipated to be achieved by 2030. So back to our prevalence, the countrywide, we are at a prevalence of 3.3, but the CIR prevalence is still a bit higher compared to the national. So the areas which are marked dark brown, the upper scale up. Why we say that the areas which have the upper scale up? Why we say this, the areas which have the upper scale up, it's because of the density or it's because of the higher number of infection. And the areas which are having light shaded areas, the areas where the sustained HIV infection are still low. Like we have from Northeastern coming to around after the coastal region, after the Western, going to part of the Rift Valley, the prevalence is slightly lower compared to the lake region of the western side and towards the coastal region of the Kenya map. Then globally, our HIV infection are also spread the way we can see them on the map. In the South American area, the prevalence is low, but the most hit place is within the sub-Saharan area. Reasons why there can be higher prevalence on those areas is also accessibility to prevention interventions. Then on the application of recency testing, recency assays, when integrated with HIV surveillance system together with geospatial analysis, can help. And the application of recency currently is mainly for surveillance. We are not using recency for any clinical management of HIV-infected patients. And that we need to note that. But now we are talking that if we can have the recency assays integrated within our surveillance and within our area of studies in HIV intervention, it can help to identify and track groups with high incidence and estimate new infections. So we can make a projection that out of this surveillance study, we've estimated these are the number with new infection. It can also help us to understand the patterns of HIV transmission for targeted interventions. As much as we're interested in knowing who is having a recent infection and who is having a long-term infection, but our main concern is the targeted interventions, which are going to reduce the transmission of HIV and the ongoing transmission, if we can reduce it, then the number of new infections will go down. To evaluate prevention strategies by assessing the effectiveness of intervention programs. So we've had intervention programs in place. So for us to evaluate the intervention programs and their effectiveness towards the prevention of HIV, we need to have the surveillance on recency assays. Then to direct resources for prevention and treatment to the most needy areas. Those areas which really need the prevention and treatment. For example, the provision of condoms as barriers, provision of PrEP for prevention. And for those who are already infected, they can have access to antiretroviral therapy, which is a management and a treatment for the infected. Then to characterize current risk factors for new infection. Through the recency assays and the surveillance, we can make a characteristics of what are the current risks or what are the current factor making those who are having new infections at risk. And if we can get the risk factors, we can evaluate our preventions and our programs targeting the prevention under the risk factors. To identify hotspots of transmission among the hardest to reach population. There are areas where even accessing testing are always a problem. As much as we've rolled out the testing to HIV testing services in our health facilities, you find that there are some remote areas where even for a client to reach a health facility is still a hardest point. To identify people living with HIV who have not been diagnosed through contact tracing. There are people who have never known their HIV status. And because they've never known their HIV status through testing, they might be infected, but they are there living in the community, not knowing that they are infected. So through the contact tracing, through the chambers of mothers, through church places, we can sensitize our groups of people to have the test, be diagnosed to be having HIV positive. Then from the index client, we can now follow up the contact tracing. To identify people living with HIV who have fallen out of care. As much as we have the tracers for the defaulters, but the ones we have in the facilities are not enough to make a follow-up for those who are defaulting care and treatment for HIV. But with the recency, after we've known they have been put on ART, because through the analysis, we can see the ART metabolites. Then these people can be brought back to care through the recency application. To identify uninfected individuals at high risk of infection who may benefit from pre-exposure prophylaxis. So once we do our surveillance and we've picked those who have recent infections, then to their partners who are non-infected, because they are at risk, but we can have interventions like the introduction of the PrEP, being given the barriers like the condom, then that will reduce the risk of them getting infected. And that is a better way of approaching the prevention intervention. Then recency testing eligibility. Not all our clients who come to the facility are eligible for recency testing surveillance. So there is an eligibility criteria. So for one newly diagnosed as HIV positive, based on existing national testing algorithm, So once a client comes to the facility, the client will be tested using the 3-tier algorithm. Once the client tests positive is when we'll have the eligibility criteria either to get this client who is positive as to undergo the recency testing assay. Then our client must be 15 years and above. Why 15 years and above? For 7 years to 14 years, the client can only give assent. The client cannot give consent. So 15 years and above, 15 years is a mature minor, and this client can give a consent for testing, which cut across even to HIV test. Then they must have informed consent. No HIV test should be done without informed consent. It can either be written or it can be a verbal consent. Then this client who is eligible for recency testing has never been subjected to a recency testing before. So it means that by the time we are enrolling this client on the surveillance, it must be the first time we are having this client on contact. Then 2, lastly, the client has never been on antiretroviral therapy. Why? Because if the client has been on retroviral therapy, once we are going to do the RITA, the recency infection testing algorithm, then the client will be knocked down when we are checking the ART metabolites. So let's have a brief look at the 3-tier national algorithm. We're just going to go through the first tester because that is where we are going to eligibly get our client as positive. But the client at the first tester will be only preliminary positive, then sent to the second tester for confirmation. So the 3-tier algorithm, we have a screening test, which is TrinScreen. So when we do a TrinScreen and the TrinScreen turns to be non-reactive, it means the HIV antibody is absent. Then we report the test as negative and we link to prevention services, where these prevention services can be, we give the barriers like the condom. We also check the eligibility of the client to accept PrEP. Then when TrinScreen is reactive, being a screening test will do a confirmation. And our first confirmation in the 3-tier test is 1 step. 1 step is now a specific test, not a sensitive test as TrinScreen. So once our 1 step is positive, we move to the second confirmation. We don't have a tire breaker, but the 3-tier, we have 2 confirmatory tests and 1 screening test. So once 1 step is positive, we move to our second confirmatory, which is first response. And once first response is positive, we report it reactive and our client becomes preliminary positive. And at that preliminary positive, we send this client to the second tester at the CC. Why at the CC? Because we've made our CC's comprehensive care clinic as a one-stop shop, such that once the patient, the client is positive from the second tester, then the client is enrolled on treatment. So in a scenario whereby our TrinScreen was reactive, we move to 1 step. 1 step is reactive, we move to first response. But if first response is non-reactive, we report our test as inconclusive, and the client is given to TSC to come again after 14 weeks. After 14 days, sorry. After 14 days, the client will come for the screening tests, and the results will continue as per the outcome of the test. Then another tree on our diagram, TrinScreen is reactive. We move to one step. Moving to one step, TrinScreen, one step is non-reactive, which means one step is negative. So if we are having an inconclusive results because TrinScreen was positive and one step is now negative. So we go back to TrinScreen. The reason why we are going back to the TrinScreen is to check the accuracy of the test, the SOPs were followed rightly, and if any case there was an error, the error can be picked. And non-reactive, then we report the test as negative, which is condom and PrEP. But on a repeat of TrinScreen, we find that our TrinScreen is reactive. Then it means our test is inconclusive. Why inconclusive? Because at the first TrinScreen was reactive. On doing the first confirmatory, which is one step, the one step was non-reactive. On repeat of TrinScreen, we get this TrinScreen is reactive. So we report inconclusive and the client is tested after 14 days. So after 14 days, the outcome will lead us to the next testing series. So if still inconclusive after 14 days, we report negative and the client is advised to be tested after 3 months. If after 3 months it's negative, then the client will now be tested using the new national guidelines. So let's look at the available recency assays we have. So the one which is point of care and the one which is used is the Asante HIV Rapid Recency Assay, SIDA Biosciences. The other one we have is HIV Swift Recent Infection Assay, which is Maximum Biomedical. It's also point of care, but not so much available in our country. Then we have the SIDA HIV-1 Limiting Antigen Avidity. It is an immunoassay. That one is laboratory based. Then we also have another laboratory based is Maximum HIV-1 Limiting Antigen Avidity immunoassay, which is also laboratory based. Then we have the genetic system HIV-1 and HIV-2 plus. This is also an immunoassay, which is laboratory based. Then we have the Architect HIV antigen antibody combo Abbott avidity protocol, that is also laboratory based. Then we have the Vitros anti-HIV-1 and HIV-2 avidity protocol, which is also laboratory based. Then we have the Genius HIV-1 and HIV-2 confirmatory biorad, that is also a laboratory based. Then we have the LIA HIV-1 and HIV-2 score, that is also extra laboratory based. Then we have the SIDA BED HIV-1 incidence immunoassay, that is also laboratory based. So far, the rapid or the point of care recency assays we have in the market are the first two, the Asante and HIV Shift Recent Infection Assay. And for what we're using as the ELISA confirmatory test for the recency, we are using the HIV-1 limiting antigen avidity. We can either use the antigen avidity or the antibody avidity, which is a laboratory-based test for confirming our recency. So just a point to note, why do we need to confirm our recencies? Using an ELISA method after doing the rapid test, because there are chances where we can have false recent report. One area where we can have a false recent report is variable immune responses to individual. There are those individuals which have a variable immune response, like the figure we saw about the recency phenomenon, where we have the acute HIV with a peak of high antigen, P24 antigen, and high HIV RNA with a lower antibody. Some individuals will not present very early with that phenomenon, depending on their immune response. Then the variable performance of the assay across the device of HIV subtypes, mainly the B antigen, HIV1 subtype B antigen. So with that, the assay can have variable performance, whereby we can have a false recent positive test. Then also, for the population with naturally low viral load, and this one is experienced in people who are called elite counselors. Elite counselors, they'll test positive, but because of their virological expression, they can still have very low viral load, depending on the neutralizing antibodies and the antigens. Then for the current use of ART, though a patient who has been on ART is not eligible, but clients can give a misinformation. So once we do that, we'll have a false recency. Then lastly, advanced HIV disease. So the people with advanced HIV disease, the antibodies are already tolerating even the antigens, because their body cannot stimulate production of antibodies against the HIV antigens. Then we have an example of the point of care recency testing, which is the Asante HIV 1-2 recency testing. The test components consist, this is a point of care rapid assay. So the test components comes either in 20 tests or 100 tests. Then we have a sample buffer, which will be in the ratio to the test components. If we are having a 20 test, then the buffer will be 20. If we're having 100 tests, then the buffer will be also 100 pieces. Then we have a blood collection loop, which picks 5 microliter of blood. Then the principle of the test. The test strip is placed into a sample mixture. The sample buffer is absorbed into its absorbent pad at the end of the test strip. This absorbent pad contains additional reagents to condition the sample and prepare it for optimal reactivity in the remainder of the test strip. Why does that absorbent have additional reagent? Because once we've placed it, we'll tap it out and then leave the reaction to take place. So that additional reagent, it's going to optimize the reaction within the test strip. The liquid mixture continues to migrate up the test strip by working action until it encounters dehydrated reagent composed of protein A conjugated to a cordal gold reagent conjugate, which is hydrated by liquid to form reddish purple color. So mainly our test principle is basically on immunochromatography, which is the color formation. But there are the reagents which are reacting to give the color formed. Then just a brief on the test procedure. Always we bring all our reagents to room temperature to attain the antigen-antibody reaction. So we label the test strip, the buffer sample, and collect sample using blood collection loop. So once we've made a blood puncture, either through capillary, or we can use a venous collected blood. Then you transfer the loopful sample into the buffer tube, mix by agitating to release the whole blood or plasma or serum. So the assante can use whole blood, which is preserved in EDTA, or we can use this plasma from the EDTA tube, or we can use this serum. Place the test strip into sample buffer tube containing sample with arrows on the test strip downwards. So once we are introducing the test strip into the buffer tube, which has the specimen, there is an arrow pointing from the sample pad. So that is what you dip that is how you dip the strip, with the arrows facing downwards. Start the timer and time for 20 minutes. Read and interpret your results at 20, not after 20, because it is antigen-antibody reaction, which is reversible by time. Interpretation of results, the conjugate confers reddish purple color to the liquid, which is used in the test strip to visualize results. As I said during the principle, that our test is immunochromatography. It's antigen antibody, then we are going to see a color formation, which is the reddish purple color. So this will move onto the nitrocellulose membranes to give reddish color. So we have a note that low false recency rate, which is comparable to the HIV-1 limiting antigen avidity high laboratory test. So that tells us that the assante recency has got very higher sensitivity compared to the ELISA test. So chances of false results are very limited. So we have our tests interpretation, 3 reading line. The first reading line is marked 1, which is the control. For the rapid test, we always have the inbuilt control. The purpose of the inbuilt control is to show us that our test is working well, and it's also an internal quality control on the test strip. So the second arrow, which is 2, this one will show us the recent infection. And the third one will show the long-term infection. So for a positive test results with assante, for a recent infection, we are going to have a line at 1, which is control, and a line at 2. And for a negative test, we are only going to have a line at the control, which is our internal quality control. Then for a long-term HIV infection, we are going to have 3 lines, a line at control, a line at 2, and a line at 3. So the arrow 1 represents a control, arrow 2 is recent infection, arrow 3 is long-term infection. So presence of all the 3 lines indicate HIV positive diagnosis with long-term infection. So that is not a candidate to proceed to the limiting antigen test. Then the presence of 1 and 2 indicate HIV positive diagnosis with the recent infection. And now that is our candidate for a limiting antigen test. So the presence of only 1 line, the control line, indicates the client is seronegative. So let's look at the recent infection testing algorithm, the RITA. So for a client to be done the return, the client must be a confirmed positive using the recommended national HIV algorithm, which means the client was tested with the first tester, then proceeded to the second tester and is now confirmed. So as this client now is collected blood for recency or done a recency test at the point of care, this client must have tested and has not been on ART, and the infection is not greater than 12 months. So if the client has tested positive and the client has got an infection of greater than 12 months and is receiving antiretroviral, so this client is not suitable for recent infection. So it's a non-recent infection. It's a long-term infection. Then if the client is a recent infection, then we are going to do the limiting antigen avidity test. The limited antigen avidity test is ELISA immunoassay. So we are going to look at the cutoff for any sample which has got an OD of greater than 1.5 using the limiting antigen avidity test. It means the candidate is not a recent infection, it's a long-term infection. But the sample that we have gotten, limiting antigen avidity test with an OD, optical density of less than 1.5, then that client is having a recent infection. So we're going to proceed to the viral load testing. Then on the viral load testing, we are going to look at the copies of the virus. So any sample which is having copies of virus, which is greater than 1,000 copies per ml of blood, then that is a potential recent infection. Why do we classify that as a potential recent infection? Because with the phenomenon we saw of the HIV RNA, at the point when the HIV is at acute phase, the copies of the RNA are very high. And that is why there is that peak of the graph. But any client tested for viral load and the viral load is less than 1,000 copies, even if the client has not been on ART, then that is not a recent infection. Then lastly, we do the antiretroviral drug status, which is the drug metabolites. So if we do the drug metabolites and find it to be positive, then that is not a recent infection because the client has been exposed to ARVs. But if the ART drug metabolites test is done and it is negative, then that indicates the client has recently acquired HIV infection. So something to note on the return. For those who are on prophylaxis, they are not going to give false positive because they are not positive. So our first step of a client to be done a recent infection testing algorithm, the client must be positive. So what is our surveillance strategy? The surveillance strategy is that recency testing can be integrated with the routine testing. But in some countries, recency testing is integrated with existing testing points such as PMCTC, OPD, HTS to help capture a broad range of newly identified clients. But in our country, we are still moving to that because we've not had a guideline towards integrating the recency testing, which is a surveillance, into our clinical diagnostic sites for HIV testing. Then targeted interventions. The information obtained from Recency surveillance helps to guide the prevention programs, such as distribution of PrEP, patina notification, scaling up of VMMC, distribution of self-testing kits, OraQuick, and condoms to the most needy. The surveillance is targeting this because testing is the entry to prevention and care. And in a scenario whereby we have the Recency surveillance in prevention, will be helping those contacts who are still negative and their partners are positive through PrEP, also partner notification, whereby we're going to have the index client, and then we build the tree by testing others around this index client. And also we can scale up VMMC, which is also reducing the chances of getting HIV infection. Then through distribution of the self-testing kits, we are going to expand our testing nets. Then training and capacity building. So if we have the Recency surveillance as a strategy, then we are going to have the healthcare providers trained on the point of care Recency testing. They are also going to be trained on the limiting antigen testing for those who work in the laboratory. And there will be a guideline on disclosure. So that can also help if there is good strategies put in place for Recency testing. The implementation challenges. We still have a lot of challenges towards implementation of Recency testing. One, we've not have evaluated risk and benefits of returning the results. So far, the results for the Recencies which have been scaled out, clients are not receiving their test back. And that is why it is a surveillance. It's not for diagnostics. Secondly, when it comes to safe disclosure guidelines, as a country, as much as we are moving and we've tried to have the disclosures, either through the healthcare assisted disclosure, still we are having a gap. And that gap, if there are guidelines as per the disclosure, then the stigma towards HIV will be reduced. But so far, the stigma has not been reduced because the disclosure, the safe disclosure guidelines are still missing. And a client will feel, if I disclose my status, maybe to a relative who is not my treatment buddy, then everybody will know my HIV status. But that is not the case. Lack of national guidelines on use of Recency results for partner notification in clinical settings. We are also still lacking the national guidelines onto whereby a client will be tested using the Recency. Then this client will start having blame game when he shares the client with the partner that have been tested have a recent infection. So there'll be a blame game. It has come from somewhere, not me. So such kind of scenarios are still giving us challenges on how to implement Recency results in partner notification. Then cost and time implication of Recency testing yet to be accessed. The cost is still evolving because we are going to do the routine HTS testing. Once we've done the routine HTS testing, then we identify our client. After identification, we also need to use the Asante also to identify this client as a recent. And after identifying this client as a recent using the Asante testing, then we are going to do the limiting antigen test and then do the ART metabolites, which is a cost. And the whole process is also time consuming. So we cannot say that the recency Asante test is a point of care where the client will have an outcome immediately. Then complex testing algorithm, which indicates that we do the recency, we do the viral load copies, then we do the ART metabolites. And that complicates the implementation because the recency Asante can be used at point of care, but the viral load cannot be used at point of care. The ART metabolites cannot be used at point of care. So that still makes the recency testing algorithm complex. Limited availability of recency assay restricts RITA scale-up. So because I said the point of care recency testing we have are only two, the Asante and the Shift. So because there are few, cost is also up. So the scaling up we need to get more resources as a country. Then lastly, need for more training before full clinical rollout. The whole process needs a better training for a better results identification, for a better eligibility criteria for us to have the scale up. Priority action points. So with increasing need of recency assay, and as new assays are being developed, disclosure of recency results to individual clients and their partners needs to be carefully considered, taking into account the associated risk and benefits. There is right to accurate information, and that is coming up in most of our bills, which are coming up as a country. But if we need to have the recency assays incorporated into our routine testing, then we need to develop, we need to get the finances to purchase the assays. We need to train or capacity build our HCPs, healthcare providers, and we also need to have a guideline on results disclosure. Why we need to have such guidelines? Because if the guidelines are not in place well, then we are even going to have cases of GBV, whereby a female client has gone to seek a medical attention in a facility, tested and told that the client has a recent infection. Going back home, the female client will not be comfortable to disclose that have been found to have a recent HIV infection. So to avoid those kind of gender-based violence, we need to have proper guidelines on disclosure of test results. Given the ongoing HIV stigma and discrimination associated with HIV status, there is a need to gather more evidence regarding experiences of disclosure of recency results to individual. As much as we are trying to make the stigma to HIV lower through counseling, through trained counselors who can take our clients through their test results, but the stigma is not over. And we need to have a proper evidence or proper laid up strategies how we are going to work about this discrimination. As much as we also working of integrating all our HIV cares into our normal health services. But still, the stigma is still with the clients. So if we can remove the stigma, then the discrimination also will go, and the integration of the HIV services into our normal healthcare will be achieved. Then projections can be made of how HIV prevalence might change over time. So if we have our recencies in place, then we can have a priority actions and that, like what we had for 95, 95, 95, the MD of 95 being tested, 95 being initiated on heart, and 95 having a viral load suppression. Then we can also have a projection when it comes to the prevalence, because we'll know out of these new infected clients with HIV, with the intervention in place, how are we going to stop the ongoing transmissions? So recency benefits. Individuals diagnosed with a recent acquired HIV, when initiated on ART, immediately quickly achieve the desired viral load, and then reduce chances highest. So as much as we say that at the acute stage of HIV, that is where the viral load is very high and the infection rate also can be very high. But if we do a recency test and find that this client is recently infected, then the intervention will help the client to achieve a quick viral suppression compared to client who is in advanced HIV disease. Because this client who is in advanced HIV disease, the viral replication are very high. The antibody production also has gone down. So this client will be having a very steep graph when it comes to the antibodies versus the viral load. Then the recency can also benefit in identifying new HIV infections through recency testing, coupled with geospatial mapping support in prioritizing HIV prevention, treatment efforts to. And with that, the recency has also helped the rollout of some programs in areas like in CIA. So most of the programs are working towards the HIV preventions and treatment. And through the geospatial mapping, we can have the priorities of those areas which will need support through PrEP, support through ART, and support through condom distribution. Through well-trained and certified testers, integration of recency into routine HTS will improve quality of services using quality assurance, proficiency testing, and supervisory visit support, monitoring, and improvement. So if we have the recency integrated in our normal programs like the PMCTC, HTS, and even in the PITC, then the trained counselors will also help to improve the quality of testing by reducing the false positive tests and false negative tests, which can be captured during the recency testing, mainly at the limiting antigen test here. Then they're also going to improve the monitoring and support within our test sites, because there will be more of initiative given to our testers. Not initiatives as being given tokens, but through the training, they'll be well acquainted with the work they do. Apart from recently now, we are only having the HTS training for our HTS counselors and the support supervisions. Key messages. So using a single rapid test for recent infection, such as Asante HIV-1 or long ELISA, tests such as L antigen, limiting antigen avidity test results without viral load and ART metabolized test may lead to a false recency. Why does this lead to a false recency? Because Asante will give us a result that this is a recent infection. This is a long-term infection. And then when we move to limiting antigen test, it's also going to give us the OD. If it is greater than 1.5, then it means that is not a recent test. But if it is less than 1.5, then it means that is a recent infection. But the viral load will now capture the actual virus in circulation. So that is why the viral load and the ART and retroviral therapy metabolites makes the recent infection test complete. Kenya has adopted recent infection testing algorithm RITA only for purposes of surveillance and research, but not for clinical management. So far, we don't have any program which is running the RITA algorithm for clinical management. For clinical management, we are just still running the national guideline algorithm test. Equally, WHO has not approved the use of recency testing for clinical management. And that is a key because for any testing to be incorporated in any setup in our country, there must be a guideline approved by the World Health Organization. And where recency test is used for surveillance, recent infection testing algorithm RITA must include additional clinical data, which is the VL and ART status, to identify false results. So the false results for recency must be eliminated such that we don't enroll a client as a recent infection using the RITA, apart from once we've done the viral load and the ART metabolites. To date, there is no still WHO pre-qualified recency testing product for clinical management. What is there is mainly for surveillance and research purposes. So recency results are strictly for surveillance reporting and not for clients. And that is why even most of the results, all the results which were done for the last surveillance, there is no report given back even to the facilities. Currently, WHO has not approved returning recency results to clients and their partners. So there is no guideline which says the recency test should be done for clinical management. The latest recency surveillance in Kenya was conducted in 2024, and the findings are yet to be released. So that makes it a challenge. But those are the key messages we need to carry home. Thank you, Asante. That is the Asante point of care test. So I'm done.
Thank you so much, Karen. This was a very wonderful presentation and excellently done. And I think you can see from the comments from the participants, it was a great learning session, very detailed and educative, just to say. And very, very many accolades. I can see somebody called Beth. She's saying, kudos, Daktari. You are my microbiology lecturer. Thank you so much, Beth, for tuning in. And many, many, many more compliments are coming in. For sure, it was a very wonderful presentation. And of course, it has elicited quite a number of questions and also concerns. And maybe we can take a moment to just read in a few of the concerns. So maybe I'll read. So maybe I can explain the first one. I can read from the first one from Anthony Nguyu. Is asking, kindly explain on discordant couples. So I don't know what exactly he wants, but that's the question. So you'd allow me, Daktari, to read them as they have come. Just write how you would want or how you feel you can ask best. So for Anthony is asking, kindly explain on discordant couples. And then I can read the second one from, okay, maybe we can start with that, Daktari.
So thank you, Beth. You want to know something about discordant couples? The discordancy in HIV infection is whereby one client is testing HIV positive and the other client is testing negative. So one reason why one might test negative and yet they are staying together, considering that phenomenon where we have the acute HIV. Some of our clients at that point is where the dissemination of the virus from an infected person to non-infected takes place. But I talked of something called variable immune responses to individual. Because of me and you have different immune responses. At that acute HIV stage, I might miss to get the HIV. But because of frequent exposure, then I'll be liable to get the HIV. And that is why we say during intervention in the discordant couple, first, if the couple is willing, the negative is willing to take PrEP is a start. Proper and consistent condom use, barrier for protection, such that this client doesn't have access to the virus. So mostly the discordant couple can come in as a result of the exposure, but the variable immune response has made the immune system of that client to prevent the entrance of the HIV. Two, we also have what we call the cytokines. So mainly one cannot get HIV exposed once. Why? Because of the cytokines, which tend to make a barrier between the CD4 cells of attachment and the virus during infection. Thank you.
That is very well. So maybe we can move a little bit faster. This is from Movin, and she's asking, can Daktari explain why the HIV positive samples turn negative at recency testing? I think this could be her experience, that some HIV positive samples turned negative at recency tests. Daktari?
Yes, thank you. Why they turn positive? I think our main reason of introducing the 3-tier testing was for the accuracy of HIV test. So in a scenario whereby we were using the 2-test algorithm, chances of Our first test picking the antibody being sensitive. The second one confirms it. Then this person is not truly positive. Then when we do the recency test after the point of care they are sent, now going to the limiting antigen avidity test, then we'll find this test is negative. So that is why we can have an HIV positive sample turning to be negative while doing the recency using the limiting antigen avidity test, because the antigen is the virus itself.
Thank you. So maybe we can move a little bit faster because of time. So allow me to bring in the next couple of questions. And this is from Benson Lusenaka. He's asking, is it possible for an HIV case to be infected with malaria? All right, Benson. And then, okay, maybe you can just take that a bit faster so that we move.
It is possible, Benson, to be infected with malaria. One, because HIV also derives your immune system, so you are prone to infection.
Very well. So I'll move to Wilfred Aria. Thank you, Wilfred, for the questions. It is said that men generally have poor health-seeking behavior and low uptake of HIV testing. How might this pattern distort recency testing data, and what hidden transmission risks could it conceal? All right, Wilfred, thank you for the concern. Daktari, if you had me.
Yes. Well, true, men has very bad health seeking. And that is why even from our database, the EMR, when we are looking at the number tested, there are very few. So this also can affect the uptake of the recency. But through sensitization, we are sensitizing everybody to go for test. Thank you.
Next, if a county like Kisumu, for example, achieves the 95 target, but HIV recency testing still shows that a high proportion of new infections, a high proportion of new infections, what hidden programmatic gaps does this reveal? And how should policymakers interpret this paradox? Okay, thank you.
Well, so far, like when I was talking about the challenges, we've not had the exact data of the recency results, the surveillance which was carried out. But I think so far, Kisumu, the infection rate, the prevalence has gone down compared to other counties. Thank you.
Okay, so this is Nancy Waruru. I think there are a lot of questions on the 3-tier testing, and we have taken note. Nancy Waruru is asking, after you report the test as inconclusive and the patient comes back after 14 days, do you retest using fast response only, or you will start with the twin screen? Okay, Nancy. I'm sure we're not dealing with the 3-tier, but we can just assist. Daktari?
Thank you. The moment the client comes for a retest, we'll start using the twin screen because that is the algorithm.
Perfect. Now, Christine Limungi, when testing using serum, do you add buffer or you leave it? So I'm not sure whether Christine is talking about the Rita or which one, but that's the question.
Sorry, Christine. It's only the panels, the PT panels is where we don't use the buffer because we've already reconstituted using buffer.
Thank you. Rehema Nyiro, when the test shows that it is recent, how long has the virus been in the body? And for long term, how long has it been in the body? Thank you. That's quite straightforward.
Thank you. The purpose of the recency testing to show us it's a recent infection, we cannot estimate exactly, but according to the viral replication, once somebody is exposed to an infection, within the 7 days, the antigen is in the body. After 2 weeks, the antibody starts forming. So when we say it's recent, then it means the person has acquired the virus within the shortest spell of time.
Okay, so that I think what she wanted to know is recent infection less than 12 months or something like that.
Yes, with the limiting antigen test, we can see our test is less than 6 months, is 6 to 12 months.
Yes.
Then we have a test for long term, is any test which is greater than 1 year.
Very well. I think that one is a quite direct response. Thank you for that. So I think there are more questions. Okay, I think, yeah, Peter Mugendi, what happened to recency testing, which was conducted till last year? Facilities no longer receive kit supply. Was it discontinued? And then the next question is Kibet Gideon is asking, are determined kits still useful or they outlawed? I think that is quite straight. So maybe, Dr. we can take those two.
Thank you. The recent recency testing, which was done 2024, cannot continue because we don't have a guideline as per the recency incorporated in clinical management. It was for surveillance and research purposes. Then determine is no longer used. The test kit which has replaced determine is called TrinScreen.
Okay, so I think Gideon and everyone else who asked this question, I think we have moved to the 3-tier testing algorithm, and we have done that presentation, and you can find it on our YouTube. But I can see is a recurring question. We shall provide more sessions to capacity build every one of us here to just know the most recent guidelines. So next question is from Quinta Akinyi. What happened to a patient who has been taking ARVs, yet the immunity has just fallen with WBCs? Okay, with a WBCs of 0.91, HB 5.8, and platelets 19. Hepatitis surface antigen, hepatitis B surface antigen is positive. Patient is too weak. How can we solve this problem for patient to become stable again? Okay, I don't know whether we can handle this, but that's the question from Quinta.
Thank you, Quinta. That one now goes to the clinician because already your parameters are indicating something is wrong. And hepatitis also being a viral infection, it's also affecting the immune system. So that's why the patient is so weak. But when the patient has an intervention, the patient will come up.
Thank you. Juliana Wambua is saying, nice presentation. Are there plans in place to capacity build healthcare providers, especially MLOs, on recency testing in rural setups like health centers and dispensaries? Okay, thank you, Juliana, for the question.
Yes, there can be capacity building so long as the recency testing has been approved by the World Health and incorporated in our testing sites, just the way we rolled out the 3-tier sensitization testing, which I know all our MLOs were trained.
Thank you. Janet Chepkorir is asking, kindly elaborate on limiting antigen avidity test.
Janet, a limiting antigen avidity test is just like an ELISA test, which was used to be done in the laboratories when we wanted to know an HIV positive client. So it's also another form of ELISA test. So what you're going to do, you have your plates impregnated with the antigen, then you read the ODs using a reader.
Thank you. Gladys Ngonjiri, and I see this is a question and a concern from many of you. I think she's asking, what does standard Q rapid test turn positive in all the 3 tests, HIV-1, HIV-2, and syphilis, when serum is used, and like when whole blood is used? Thank you, Gladys. I'm sure we were not handling this, and I can see many questions regarding the 3-tier testing. We have taken note, and we shall schedule sessions to capacity build ourselves on these guidelines. But Dr. if you have any insights?
Well, the standard queue was having an issue, but areas which it had an issue, one, it was the personnel because of the pipette. So for a false results, we have to do a kappa on all the areas around. It's not the test kit, but we have to do a kappa on all around.
Okay. Very well, Dr. I think we have come to the very end of today's learning session, and I think there, from where I sit, we can see a lot of concerns on the three-tier testing algorithm, and we have taken note of this, and look out for this session, because we shall plan it soonest so that we're able to capacity build ourselves, we're able to learn the challenges that we are facing from wherever we are practicing from. And I think this is an indication that this is an area that still needs attention. So we have taken note, and we shall be able to arrange for this session. So from where I sit, Dr. I want to take this back to you to give you a closing remarks.
Thank you, comrades, for giving me a hearing and for the nice comments. Let's meet maybe when we are doing a three-tier again.
Wonderful, wonderful, wonderful. Thank you for that. And for everyone who found time to tune in, it was a wonderful session. And we are hoping to get in touch in our next presentation, and see you then.